Hello, this is Jacqueline Eckern with Eating Disorder Hope, and today I have the privilege of interviewing Chase Bannister regarding the Eating Disorders Coalition. With that, I'd like to introduce Chase and let him tell you a little bit about himself.
Well, hello, Jacqueline. Thank you so much for having me and having, by proxy, all of the Eating Disorders Coalition here with you today. You have done such incredible work for so many people for so many years, and it is meaningful. And I just wanted to say thank you for that. Having moments where, particularly now, to connect in a time where connection can sometimes be difficult, you've made a pathway to bring information to people and groups and communities, and that's frankly in my world sort of priceless. And to have an opportunity to sit here with you from my own living room to wherever you may be, just that's an incredible opportunity, and we're mindful of what you've done. So I hope you're proud of yourself as much as we are proud of you. Uh,
Thank
so my
you.
name is, you're welcome. Absolutely. My name is Chase Bannister. I am a licensed clinical social worker and certified eating disorders therapist. Been doing this for a number of years, working as a clinician in eating disorders for many years. I started at Duke University Counseling and Psychological Services back in the day as a therapist, graduate clinician training, and they assigned me a supervisor. And in school, and this isn't probably going to come as a shock to many of your listeners, but I don't know, a lot of clinicians when they go through school are told, well, work with just about anyone. I remember the day this happened in class. Do the things that you can do well, the easy stuff like PTSD, other traumas, anxiety, depression, uh, guilt, shame. But whatever you do, don't treat eating disorders. Like that was an actual thing. I remember where I was sitting in the room when I heard it, and I actually didn't know anything about eating disorders. As you and I also know that it's curricula around the United States for mental health providers and psychiatrists, physicians, nurses. It's getting a little better, over time. But that was some moons ago. We'll not quite say how many moons ago it was for me. But I took that to heart. Okay, I won't do, I'll not do that. Well, I get to Duke, and lo and behold, they placed me with a supervisor who was an eating disorder specialist and therapist. And I thought, oh boy, what am I supposed to do? This isn't how it was supposed to go. They told me to not, whatever I do, don't work with eating disorders because, and I quote, they don't want to get better. Uh, and and I believe the term was, and you'll hate yourself for doing it.
Wow.
And now I have been suddenly placed in this environment where I was, you're going to do this, and my supervisor said, well, you don't have to do it. You can do, advanced general work, what have you. And she just lied straight to my face. Because within about 2 weeks, my entire caseload was suddenly full of university and graduate students with eating disorders. And I am grateful for that lie. There aren't many lies in this world that I'm grateful for, but that little one was okay because it got me through and introduced to some of the most creative, passionate, wonderful human beings in pain and in who have who were in environments that are particularly strife-ridden, university environments, high academic achieving groups. University environments we know are places where eating disorders love to thrive. Uh,
Yes.
and I thought, something is not clicking here between what I was told I was expect and then what I'm having in the room, because I certainly saw and what worked with so many young folks who wanted to get better. And that's not what I was told. They weren't supposed to want that. They were supposed to be difficult to work with. And frankly, I got a little mad.
Yeah.
A little mad about what stories had been, passed along through clinical generations that led to that moment. because that made me think, okay, how are we then? Is it perhaps by some bias that we're underserving this population? That we've decided that the mantras, the old ideas of, well, it's only a rich white person's disease, um, and I already was seeing in the student population there that that was not true. Demographically and otherwise was not true. Um, and I saw so much need. So actually, after finishing my residency there, uh, actually went to start Carolina House with another clinician in Durham, North Carolina, a residential treatment center for women with eating disorders. Started it as a 6-bed facility, then grew it to, 8, 12, 16, and then, working on other sites. So and the need was enormous. The need was potent. Um, and then another need popped up because we treated folks who were 17 years of age and older, when we first opened Carolina House. Um, uh, and and we were getting applications for treatment from folks whose handwriting I'm like, looks to me here like perhaps a mom or a dad or somebody else maybe filled this out, because this isn't in the script I would typically expect. And sure enough, some families were fudging on their children's names to try to get them into care. They were so desperate for somewhere to care for their child. Um, and and many of them have been through what the best practice treatment had been, which was family-based therapy. And I really do believe strongly that that should be first line for many folks. But many of these folks had done it, it hadn't worked well. And all right, so well, what do? Well, you create something new, and you. So I was the founder of Veritas Collaborative, a specialty healthcare hospital for the treatment of children and adolescents with eating disorders at the time. Now it has grown into treating all ages at all levels of care, particularly along the Atlantic corridor, with hospitals in Atlanta and Durham and Research Triangle Park and clinic in Richmond and Charlotte and beyond. Um, and so never put it past, never put it past a social worker to find where there's a need and try our damnedest to find a way to meet it in the best way we can. As part of my work at Veritas, I was, privileged to also be a part of the larger eating disorders community, in helping. I'm joining the board of the Eating Disorders Coalition and helping craft the legislation uh, that ultimately became the 21st Century Cures Act, and is the first time that eating disorders were recognized and written into federal law. Um, and right at the end of December in 2016 is the last bill that President Obama signed before leaving office. I spent a lot of time. I spent so much time traveling back and forth to Washington D.C. Um, Meeting with folks, learning from folks, meeting with providers and treatment centers, and hearing about what they need and want, and hearing from what family members, and unfortunately throughout the ages, even having to eulogize too many children. That is uh, an honor to be asked to do that, and also uh, incredibly painful, and as well it should be. These are deadly illnesses, that eating disorders across the spectrum is in some ways often silent killers. Um, and I realized we needed to do better. We needed to do more. So I was asked to serve in the role of president of the Eating Disorders Coalition, the board of directors, and I have for the past 2 years been serving in that capacity, and gotten a lot of things done. Um, you know, all the way back to 2016, getting some Department of Defense funds for military eating disorders research, and getting about $5.5 million in eating disorders funding made available at the time. And uh, being able to work with the Office of Women's Health at the Department of Health and Human Services to update very antiquated literature they on eating disorders as a public resource. How we had to dig in and help change that. Helping parity come to fruition, making sure that eating disorders and physical disorders are treated on par with one another. Um, uh, you know, Working with health training, funding for health trainings, and we actually were able to a big deal. We were able to secure almost $4 million to establish uh, the United States' first National Center for Excellence of Eating Disorders. And that was eventually awarded to Dr. Christine Pete, Sandy Bulick at University of North Carolina, Chapel Hill. And so a lot of work went into finally getting those dollars. But then now we've got, Christine and Cindy doing some of the most remarkable research, and it really is changing lives. Sometimes it's a long slog to getting stuff done, but we have to have strength for the journey and be in it for the long haul in order to do what we're supposed to do on behalf of our patients, our families, those that we are called to serve. Um, so there's so much that we have done beyond that, and we're constantly working on new things. So, um, and Jackie, I don't know if you want me to talk about some of those new things or what
Yes,
you.
please. I'd love to hear what's currently going on for y'all.
Oh yes. So glad you asked. I set myself up for that question, and I will admit it. In about a week's time, we will be having our annual Advocacy Day. Now, for the last about 20 years, that Advocacy Day has been in person. We get people on planes when that was a thing. Uh, and we would get them to go to Capitol Hill, and we would get them meetings with congressional members of Congress and the Senate, as well as, of course, largely their staff members, get them face to face and telling the story, and clinicians, providers, centers, researchers, certainly, folks with lived experience, and we get them to the Hill, and we have team leaders that lead them around and talk about policy, ideas and pitches that we want to have to sort of frame the forward discussion on eating disorders, and really do our part to create eating disorders and nail down eating disorders as a federal mental health priority, and in the public health space in the United States. And I think a lot about how my feet hurt when we do this, because it's a lot of walking all around the Capitol, into the office buildings, and finding the staff, and reaching out and talking about our different policy issues. I always say that, though, that there's a saying that is attributed to some of the marchers in the civil rights era, um, uh, who saying that my feet are tired, but my soul is at rest. And I uh, and I find that to be true every time, your aching feet when we always tell folks never to wear a new pair of shoes. Wear an old broken pair of shoes are going to be fine, because if you get new shoes, you're going to regret it. I can tell you personally, because I did that one year. I got a "told you so" from a couple of great folks. Well, this year we can't march the halls. This year, um, uh, you know, uh, and I worried. Our executive team worried. The field worries when we don't have as much access. If we're not there, those, much like therapy, it is, very, very important to have, do a phone session, what have you. But sometimes the in-person touch is needed, and I worried that was this is all not gonna go well. We wouldn't get anybody to register because he would be interested. Well, I always say I reserve the right to be wrong. because I was wrong. Because I learned from our wonderful policy team at Center Road Solutions, led by Katrina Velasquez, our lead policy sort of leader, and her team, Allison and Luke and others who live in Washington D.C. and carry out lots of things on our behalf. I learned from them that maybe there's a way that we could do this, that we could use technology and still make this work and still really get our voices heard. So we sat around the table and we thought and we dreamt and we figured out with again this great team, Center Road with Katrina Velasquez, and we have Zoom meetings now instead of which of course now we're on Zoom, you and I right now. We're going to be doing Zoom calls in groups of about 5 or 6. Each team of 5 or 6 will do, maybe 5, 8, 5, 6, 7, 8 meetings that we will have scheduled for them so that they can be face to face with their elected leaders and their senior staff folks. And I underestimated because now we have far more registrants for this event than we ever have. We have over 200 people already, signed up. There's still a handful still trickling in. They're, just a little late in getting the registration. But that means also hundreds of meetings that have been set up, where folks, and this is the cool part for me, folks like from the West Coast, it's a lot more difficult to get to DC. It just is. It takes more time, and a lot of people take time either off work or what have you to go. But in this weird environment where I thought things would go to pot and it wouldn't be great, that's an old Southern expression. It would just be terrible. I can't. There's so much energy and excitement and enthusiasm around it because here's what we're talking about. We're talking about what's called the Nutrition Care Act, and it's being introduced, and it's sort of really brass tacks is making sure that folks on Medicare, and are able to receive nutrition counseling and have that covered, because you would think, well, of course they would have that covered if they're someone who is receiving Medicare, either through being a person who's disabled with Medicare or a person who has reached 65 or older with Medicare. You'd think, well, nutrition visits would be covered, and in fact they are covered for folks with renal disease, chronic renal impairment, and people with diabetes. They get a standard amount of what we call medical nutrition therapy. But if you have an eating disorder, you're out of luck. It's not covered, and so it has to come out of your pocket. Um, and what we consider like the 4 pillars of mental health care being, therapy, psychotherapy, internal medicine or pediatrics, psychiatry, and nutrition and dietetics. And that it really does take that village of providers in order to offer the most quality care. And missing any one of those pillars makes recovery far more difficult and lots more unstable. So it didn't make any sense to us that there's no provision in the law to allow us to get care for folks with Medicare, to get dietitian visits covered. So our bill does that, allows for it to be covered, and you know, and knowing that it already does cover it for diabetes and renal failure has helped us very much. We have wonderful leads in the House and the Senate, and as you and I have talked before, all of our bills, any bill we ever do, it's a sort of internal rule here, is going to come out of the gate as bipartisan. Because eating disorders are not a partisan issue. Just because we're walking the halls of Congress or virtually walking the halls of Congress, there's not a side here. Eating disorders are lethal mental illnesses. And even thanks to Striped and Boston Children, Harvard, the Academy for Eating Disorders, and Deloitte for doing such a fabulous new report that taught us we were undercounting eating disorder illness. We were even underestimating lethality. We once were able to say, even just 6 months ago, that we said, one person dies every 62 minutes from an eating disorder. That's now no longer true. We now have to redact that and say one person dies as a direct result of an eating disorder illness every 52 minutes. That's not a good trend. And so we need to be talking about it. And we've got some folks, leading our on our House side for the Nutrition and Care Act, and CARE is an acronym for Counseling, Aiding, Recovery from Eating Disorder Act. Representative Judy Chu from California, Jackie Walorski, I believe, Republican from Indiana. And on the Senate side, we have Senator Hassan from New Hampshire and Republican Senator Lisa Murkowski, all who have signed on. So already out of the gate, we have a Republican and Democrat in both chambers agreeing on something.
Wonderful, yay.
And we continue to we have at least 35 bipartisan co-sponsors, and more will come because we usually get a big uptick after advocacy days. So 35 is going to be a small number compared to what I'll be able to report in a couple of weeks. And we're not asking for more than what folks with diabetes or end-stage renal disease get. We're asking for the same amount. If there's however much coverage they get, we want folks who are diagnosed with an eating disorder to also be able to access that care, because it makes not only financial sense, but more importantly, it makes sense to care for these very vulnerable populations. Now, some have asked me, well, Chase, does it really make sense to do with we do see the numbers, and that there are lots of folks who are much younger than 65 perhaps, who maybe that should be our focus. And I want people to know, and this isn't some major secret in the universe, but there's strategy for us. Why did we choose Medicare? We chose Medicare because that's what commercial plans and Affordable Care Act plans / Obamacare plans, those employer-based plans, that's what they look to as a benchmark for how they're going to create their policies, their insurance, what they're going to cover and not cover. They often look to whatever Medicare covers. That's usually a starting place for how everything else gets developed. And so if just walking it through that way with you, I hope that folks are able to see that what we're doing is trying to set a standard so that one day, and maybe one day not so far in the future, we'll be able to get commercial payers and employer-sponsored plans and all the other plans in the world to follow the standard Medicare rather, sets up for us, and that's a big deal. So that's certainly one of the things that we're going to be doing. We also have sort of timely, in terms of telehealth.
Yes.
Everybody's relying on this. We have got to have it. Like we really do have to have it, but not everybody gets it. In fact, there's in the pandemic we've had that has touched so many lives. It may be that some 70% of folks, their plans are under emergency basis allowing for telehealth coverage, but there's still some 30% out there who they haven't budged. Then the insurers or groups haven't budged, and that forces folks to sort of choose between their because this costs money, so that between their mental and physical health care, and that's really not okay. There are a couple of bills that we're working on to make sure that folks can get access to telemental health and other provider services, at least for the immediate future, and make that as universal as possible. In the House, there's the House Care at Home Act 6644, I think, and it requires both those employer-based plans, like those, which a lot of America has those employer-based plans, and the Affordable Care Act plans, that they will, during this public health emergency, anything that could be provided in person will be also covered at the same rate it would be covered in person over telehealth. It's a little bit different in the Senate bill. The Senate bill is the Telemental Health Improvement Act, 3792. I'm going to get in real trouble at some point for me looking up a number. Katrina's going to be on me, and you can know when I say it that whatever Katrina says is the right
Okay,
answer.
gotcha.
But that will, while it doesn't cover the Affordable Care Act plan, it does focus in on those commercial plans that almost 60% of America depends upon, saying that payers can't put up barriers to care, and it requires Health and Human Services to report on telehealth policy practices. That's a big deal. Of course, again, this is all immediate term during the public health crisis. So, that's pretty amazing. Excuse me. That's led by, on the House Healthcare at Home Act, that's led by Kim Schreier of Washington, Phil Rowe of Tennessee. On the Senate side, I'm definitely trying to look at my notes and make sure I remember, because I want to give these folks credit. Senator Tina Smith from Minnesota, a Democrat, and again, Senator Murkowski, from a Republican from Alaska. So, like before, anything we're going to support and put forward, we're going to do that in community, and we're going to make sure out of the gate that it has bipartisan support. So those are our two major asks this year: to get medical nutrition therapy covered for folks in Medicare, the strategy of helping, frankly, all the other groups cover dietetic services, and two, to make sure that folks are able to get access to at least different levels of care, different treatment, um, and get that covered at a rate that is acceptable, such that the providers, can still continue to offer it, and such that they can access care as safely as possible from their homes. And so that's what we'll be virtually doing, and tagging in from folks from all over the world. I told, I think I told you right before we started recording that it's always dangerous to get me talking about something, because I learned a word a long time ago called laconicism, and it means, being brief and really succinct. I don't have that gift, um, because when I get passionate, I like to talk. So, and to thine own self be true, and let's not lie to ourselves. So, yeah, that's rambly me, but it's all of this is so critical, and we can make a difference. I've seen it happen. I was there in the room in the Senate chamber in 2016 when Vice President Biden, which is his last act as the outgoing vice president, was signing the 21st Century Cures Act into law, alongside, of course, his son's the Cancer Moonshot Initiative, named after Beau Biden. And we were in the room, and the Anna Weston Act, as it was normally called, called Kitty Weston, being just a rock star, a person whose her daughter died of an eating disorder many years ago now, and so we asked if we could name the bill after her, the Anna Weston Act, and then she was actually able to be in the room with the president as that act was signed into law, and eating disorders were, again, for the first time ever, recognized in our federal codex of laws. That's a big deal, but it's just a start. And the road ahead is a lot, and our resources are small, and we need to find ways to do more and better outreach, we depend upon communities like our wonderful sponsors, the members of our organization are like NEDA and the Residential Eating Disorders Consortium. You guys, also the Alliance for Eating Disorders Awareness, and the list goes on and on and on of some 54 members, coming together and saying, let's have a voice where we step up and we say the same thing and we say, hey, we're united. There's a reason that we're called the coalition, um, and and because it really is about bringing folks to the table. And when we do, there's no limit to what we could do, and there are lives that can be saved, and there are people who can get care and whose lives can be made more fulfilling and rich, and not perhaps caged by some of the anxieties, fears, and physical deteriorations that we know eating disorders cause.
Chase, your passion is so exhilarating to watch, and I thank you for all of your service and the Eating Disorders Coalition's work. If someone would like to sign up to advocate or become a member, how should they proceed?
Oh gosh, right now there, I would encourage you to go, first of all, go look us up on the web, because that's what everybody does. You can type it into Google or Bing. Is Bing a thing? I don't remember. I'm not always the technological guru, and so I need to be honest. But go to our website. There's contact us links there. Even though the window has closed, there are maybe a few opportunities in specific areas, because it does take a lot of work to schedule all this, and we're about a week out. But nonetheless, we want to hear from you. Luke Kopetsky leads that connection, and his name is so his email address is lkopetsky, Kopetsky, Kopetsky at eatingdisorderscoalition.org. If you have a particular interest in joining up for this day and you just really, really want to do it, which, gosh, he may get a little mad at me for for suggesting it at a late hour, but beyond that, we would love to have folks come and become members. Any organization that might be out there that wants to be a member, any individuals that want to gather together and donate, there are ways to do that, because every dollar counts. We put it to work. I guarantee you, we are as transparent as we can about where we spend our resources, and so that we can really make a difference for all of our constituents, because that's, we're in this together. So this is a shared purse. And while we sometimes the journeys are long, we have to step up, and we have to say, all right, now's the time. Now we're going to do it. How can we get scrappy? And that's I tip my hat to all of those leaders who, for years before me, started saying, hey, listen, because I can praise EDC, all day long, or say I did this, I did that, but we only exist on the backs of those persons who for years said, please. For years it said, somebody help. For years it said, we don't have any funds to figure out what to do. We don't, how do we go forward? And because they didn't stop in that quest, we now exist. And it is now both a burden and a honor of the highest caliber to step into those shoes and say, all right, now let's help, let's do it. And yeah, I will talk about that all day long, or as we would say on the farm back in South Carolina, where I'm from, till the cows come home.
Till the cows come home. Chase, it has been a privilege to spend this time with you. I know that families, those dealing with eating disorders directly, providers, will all drink this information in. It was such a great overview of what the Eating Disorder Coalition does and what you're doing right now to help eating disorder sufferers. Thank you.
My privilege, Jacqueline.